So Crystal and I had the pleasure of seeing a patient together, and we thought it was a very interesting case and a very good teaching case. And it's going to highlight some of the things that we do in vestibular rehab, as well as some of the not so usual audiological tests that are performed. And so we thought we'd share that with you today. It's titled Athlete with Vertigo. Is the cause peripheral or central? Crystal and I both work at Michigan Balance. And it's within the Department of Otolaryngology at Michigan Medicine. All right, Crystal, next slide. We have nothing to disclose. So our case is a 20-year-old University of Michigan. He's a junior in engineering, and he is a cross-country runner. So he runs for the club team, very athletic. He woke up on December 1st with nausea, vomiting, spinning, dizziness, vertigo, imbalance, spent the whole day in bed. He reported some mild cold-like symptoms 2 to 3 weeks prior to the onset of the vertigo. He was seen by his primary care physician the following day, and they performed a modified Dix-Hallpike test, which was negative. But their impression, when I read their notes, said possible BPPV, possible dehydration after some intense running workouts the 2 days prior to this. Their treatment recommendations were to hydrate, take some Zofran for the nausea, and start Cawthorn-Cooksey exercises. So I'm curious, anybody in the audience, any thoughts on, does this case sound like BPPV to you?
I would say not really. Usually, as you know, BPPV is short episodes of vertigo, and this doesn't sound like what he was experiencing. And usually people don't have to spend the entire day in bed. They can find positions that are comfortable. Some people definitely feel off when they've got an acute attack going on, but usually wouldn't present this dramatically.
Right, I agree with that. And I'm surprised that they recommended then something called Cawthorn-Cooksey exercises. So go ahead, Crystal, next slide. So Cawthorn-Cooksey exercises are actually habituation exercises. They were introduced back in the 1940s when vestibular rehab first started to actually help soldiers after concussions in the war. And basically what they are is a series of head and eye movements that are more under the habituation category, meaning these movements may make them more dizzy, and the idea is to desensitize their brains to the dizziness by doing the movements within certain guidelines. But they're definitely not usually used in the clinic wildly now because we have so many more better exercises that we can prescribe for patients. So bottom line is they weren't going to hurt him, but I didn't feel like they were the best exercises to prescribe for this patient. All right, next slide. So, if you're considering that it is BPPV and Dix-Hallpike test is positive, then I'm hoping that the physician would do a Epley maneuver, or at least get them to a physical therapist who knows how to do these treatments. All right, Crystal, next slide. So he then went to see the team doctor at the University Health Center a couple of days later. His dizziness continued. He was trying to attend his class lectures, but he stated that it took 2 times as long to walk to any class. Quick movements would very much increase his symptoms. And then he would get these interesting uncontrolled body shakes or tremor at times. He denied any hearing loss, tinnitus, no pain in the ears. His neuro exam was actually pretty good, except for the doctor noticed some head shaking at the end range of lateral eye movements, and he had a very wide base gait. So in a young person, would you expect a wide base gait with someone with just a peripheral vestibular insult?
No, that would be pretty concerning.
Yeah, I was a little concerned about that. Okay, so next slide. All right, so go ahead, Crystal, go ahead and hit it again. So he went to see the team doctor a week later, so now he's 2 weeks post-onset, and he no longer has a constant dizziness, but he describes this motion-provoked dizziness. He reported shaky vision, stating it was hard to read, and then when he was walking, he really had trouble focusing on people's faces. He was working with academics to get some accommodations for his finals. He still had some body shaking, especially when he was very anxious. The neuro exam revealed some occasional hand tremor, and the doctor described some intermittent resting nystagmus, which at times was rotational. Patient reported that meclizine was not helpful. So any thoughts on diagnosis at this point?
Not really a specific diagnosis, but I think at least most of the things that you've presented seem like central issues. If he has nystagmus that's potentially changing directions, the gait issue, the shaky vision and everything might be oscillopsia. So unless there's a concern that he has bilateral peripheral issues, I think it's probably pointing towards a central issue right now.
Okay. All right, go ahead, Crystal. So the recommendations at this point were compazine and diazepam, brain MRI, and vestibular physical therapy. When we see our patients, really caution them about use of both meclizine and the benzodiazepines because we feel like it may limit their compensation or their ability to progress through the vestibular rehabilitation. When I saw him on 12/19, so now we're 18 days post onset, he reported feeling about 60% of baseline. At this point, he still had some motion-provoked dizziness, mild imbalance and blurred vision with quick head movements, occasional body tremors. He was not able to run at this point and it was not driving. He did make it through his academic semester, didn't do quite as well as he had hoped, but he did survive. His mother accompanied him, and she was very concerned for a serious pathology. Past medical history just included anxiety. He did have COVID about 6 months prior to the onset. We have our patients do something called the Subjective Dizziness Handicap Inventory, and his score is 28. And I'm going to go ahead and go to the next slide, Crystal. So this kind of shows the Dizziness Handicap Inventory, which is a series of 25 questions where the patient will answer yes, sometimes, or no. Yes, answer is worth 4 points, sometimes 2 points, and no, 0 points. So the higher the score, the higher the perceived subjective handicap related to dizziness. I like to screen this and just get a total score. Scores over 60 typically tell me that the patient may have some kind of overlying psychiatric overlaid to their presentation as well. So it helps us and prepare for seeing the patient who may have more anxiety, that kind of thing. I also like to screen, look at questions that involve related to BPPV. So that is question P1. So does looking up increase your problem? P11, do quick head movements increase your problem? And then P13, which is turning over in bed. And then number 25, which is bending over. So if they answer yes to all of those, I'm going to make sure that I definitely include a Dix-Hall-Pike test in my exam. Okay, go ahead. So physical therapy, we do our own evaluation, and that does involve many balance and gait outcome measures, as well as some bedside vestibular tests. And on this date, I have him perform the Romberg test with eyes open and eyes closed. And he was able to do that for 10 seconds. Where he really struggled was balancing on the foam surface. So the compliant surface, he was only able to do 5 seconds with his eyes closed. As we know, patients, or we all use our eyes, our inner ear, our proprioceptive system as the main 3 components of our balance system. And when he was left to rely on just vestibular, he really struggled with it. Dynamic visual acuity test is something we do on a regular basis. So what this involves is a patient will be sitting across from an eye chart. They're going to read the lowest line that they can see on their eye chart with the head still. And then we help them move their head at a speed of about 2 hertz, so about like this, trying to read the eye chart, going up 5 lines and then see if they can get close to the line that they read with a stable vision. And he only had a 2-line difference, which is considered within normal limits. I had him do some pursuits and saccades, which I'll show you in a moment. Hopefully our video will work and you'll be able to see this, but I felt his pursuits were smooth, but he had this interesting kind of bouncing, resetting movement when he did some saccades. I did a near point convergence test and noted that his right eye wanted to abduct at about 7 to 8 centimeters away from the end of his nose. This may be something that was there underlying, not sure. but it didn't seem to bother him too much when he was reading. I did a horizontal head impulse test, which was equivocal bilaterally. I really expected it to see positive on one side for possible unilateral hypofunction, but it was a negative test. And then when he did perform tandem gait, he really went into this very tremulous, all over body performance that was very interesting to see. Okay, next slide. So my impression was possible vestibular neuritis, but definitely consider some central causes as well. And I was concerned because he's an athlete. Go ahead, Crystal. And he was able to do balance on foam, eyes closed. He had this equivocal head impulse test in the setting of bouncy saccades, and he had this tremor with a tandem gait. So the plan for him was to initiate some vestibular exercises, and I'll show you those in one moment. And then I wanted to get him into the other clinic where I do have access to video goggles and do my video goggle exam to see if that could shed some light on this diagnosis. So when we treat our patients, we use evidence-based treatment, and the treatment is very individualized. And oftentimes we look to the clinical practice guideline for vestibular hypofunction, which was revised in 2022. And the recommendations from the clinical practice guideline are that we definitely include 4 different types of exercise for treatment of persons with vestibular hypofunction, at least. The first and most important category is adaptation, which has to do with gaze stabilization. So we're trying to stabilize the vision as the head turns. And in athletes, this is especially important, especially if they're an athlete who has to do a lot of head turning on the field, that sort of thing. And we're going to go over one of these exercises in just a moment. And then again, we do some habituation exercises. So the movements that make them dizzy, we have them do within certain guidelines. We love to use a 0 to 10 scale where 10 is terrible dizziness, 0 is no dizziness. And we allow them to, when they do certain movements, get up to a 4 to 6, so a moderate range dizziness that then decreases back to baseline within a couple of minutes. So that way our patients are not feeling sick and overwhelmed the whole day. We have them do some balance exercises. So in this case, I had him working on some foam with adding some head movements, trying to do that eyes closed to really upweigh the vestibular inputs. And walking is often a very important component of anybody's home exercise program too. We really have found that walking is the best aerobic exercise to help integrate the eyes, the inner ear, the feet all together. So it's superior to something like the elliptical or stationary bike. Even though those would be good for cardiovascular, they're the best for vestibular is actually walking. He was also educated in factors that which can negatively affect his outcome, including stress, poor sleep, dehydration, lack of physical activity, and medications, especially things like meclizine and Valium. All right, Crystal, next slide. And so VOR exercises, also called gaze stabilization, we have our patients use a target, and I don't know if you can see in the picture down below, there's an X on the card, but those of you that want to try this morning, you can hold out your thumb in front of you. And what you're going to do is keep your eyes on your thumbnail while your head starts moving about this distance back and forth. You're trying to keep your thumbnail as clear and steady as possible while you gradually increase your head speed. And if your VOR is working normally, you should be able to go at a speed of about 2 hertz. So about like this, and have a stable vision. So we have them work on that both horizontally and vertically. And so I started him on these exercises as well as some balance exercises. All right, Crystal, next slide. He came back to see me 3 days later, reporting that he felt now 75% of baseline. He continued to have some dizziness with head movements. At this point, I did a couple more gait outcome measures with him, and the only one he really struggled with, with 2. One with walking with horizontal head turns. He had some path deviation, and he was able to do tandem now, eyes open, a little bit better, but when he closed his eyes trying to do it again, he went into this leg shaking, body tremor kind of scenario. I repeated his horizontal head thrust test, and it was clearly negative bilaterally. All right, Crystal, next slide will show you this video. Okay, so video goggles are on, meaning he is in the dark. Anybody want to comment on what you see? We're looking at him. So this is, yeah, kind of the perspective that we're looking at him.
Can I'm sorry, I can't mute it, Wendy.
That's okay.
Okay.
It looks like there's some, is it left beating nystagmus, just kind of slow?
Yeah, there is. I'm glad you can see that. So a little spontaneous left beating nystagmus. I didn't feel like it was still present when he gazed left, but I did not feel like it increased in intensity. Not really there when he gazes to the right. When he gazes upward, still there slightly. It's back to center gaze. Downward gaze is hard to see. And gaze to the left one more time. Again, I feel like it's there, but doesn't increase. So it really doesn't follow Alexander's law. I took the cover off and now he's in room light, and I'm going to have him do some smooth pursuit here a moment. Okay, smooth pursuit. Which I think looks pretty good.
Mhm.
It's gonna do some saccades. So I don't know if you can appreciate that kind of bouncing,
Yeah, like
not quite horizontal eye movement I hadn't seen before. Okay, so now I'm just giving him instructions. I'm going to put the cover back on, I believe, have him close his eyes and do a head shake test. So I did not appreciate any post-head shake nystagmus, which again, you would expect to see if someone had a peripheral vestibular hypofunction in most cases.
okay.
All right, go ahead, Crystal, next slide. So just kind of thinking about what we've seen so far and trying to compare at least unilateral hypofunction with central findings and then our case findings. So for pursuits and saccades, in a unilateral hypofunction, we expect them to be smooth and accurate. If they had central pathology, we might see some saccadic pursuit or hypometric saccades. And in this case, the questioning a trait that we saw with some bouncy saccades. Dynamic visual acuity, usually we expect to see anywhere from a 2 to 5 line DVA in someone with an acute unilateral hypofunction. Those with central pathology may be describing diplopia, and our case findings were that he just had a 2-line DVA, which was considered normal. Video goggle exam in a unilateral hypofunction, again, you would expect it to follow unilateral direction of nystagmus that follows Alexander's law, meaning that if it's left beating, when they gaze to the left, it's going to get stronger, and when they gaze to the right, it's going to be weaker. In a central pathology, we would see direction changing gaze nystagmus. So if they gaze to the right, it would be right beating. If they gaze to the left, it would be left beating. In our case, we saw the left beating nystagmus in two both central gaze and left gaze, but it didn't really increase. And then we didn't see any post-head shake nystagmus, so it doesn't really follow Alexander's law. His head impulse test again was negative, and we would expect to see it positive with someone with a unilateral hypofunction to the involved side. Those with central conditions typically have a positive Romberg test. And then tandem gait is kind of we don't really have any true guidelines, except for we feel like it's more age dependent, and those with central conditions typically would have quite a bit of challenge doing this. Okay, so thoughts at this time. What would be your next recommendation for this young man?
So we have three fellows besides, and we have Susan's one, there's Stephen and Armine. So feel free to rotate those questions. So Susan's not bearing the brunt of the load. Stephen or Armine, step up.
He's certainly making some improvements, but I know that there was a recommendation earlier to obtain an MRI. I would certainly be interested in ruling out any other anatomic causes. And then as far as his vestibular rehab, he's continuing to make some progress. I'd want to continue that.
Yep, agree with that. Are there any other tests that you think this young man needs from the vestibular realm? Just to go on and push the next button, I think this might help. So what I found was when he was doing gaze stabilization exercises, horizontal component, not bad at all. He was able to do it pretty well. When he did vertical, he said, oh my gosh, everything is bouncing, 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 bouncing. Any thoughts why that is happening? I'll give you a hint. Think about your vestibular anatomy. Especially when it comes to the nerves.
All right, so I'm gonna jump in here now and kind of drive through the slides with you guys. At this point, we actually are very fortunate in the setup of our clinic. So we do have the advantage of working together with other audiology colleagues, so audiologists, as well as other vestibular PTs. So sometimes we can just walk down the hall and tap someone else in. As audiologists, our role in the balance clinic is that when we evaluate dizzy patients, we can offer a variety of evaluation procedures, including audiometric assessments, as well as various vestibular assessments. So some of the tests that we can complete in the balance clinic include VNGs, rotational testing, computerized dynamic posturography, video head impulse or VHIT testing, as well as vestibular evoked myogenic potentials. I'm not going to actually cover all of these types of testing in detail because they don't all pertain to this case. But on this date, Wendy was able to reach out to one of our other audiology colleagues, Dr. Devin McCaslin, who agreed to perform VHIT testing on this patient in between his own. So Wendy has already covered kind of in a previous slide that she did horizontal head thrust testing or head impulse testing, which can be performed anywhere as part of a bedside evaluation. But in the lab, we're equipped with a video goggles system that will actually allow us to record eye movement data while performing the head impulse test. So it allows for testing of the lateral semicircular canals as well as the vertical canals in each ear. And it will record eye movement gain as well as capture any covert or overt catch-up saccades that may occur during the head movement. So if the person has a weak VOR input and their eye is slipping off of the target, there will be these little quick saccades that can be generated to get their eye back on target after the head is moved. So for this test, the clinician just stands behind the patient, instructs them to stare straight ahead at a visual target at eye level, and then the clinician performs a series of quick head thrusts in either the horizontal or vertical plane for the canal test all 6 canals, 3 in each ear. So on this date, Devin was able to perform the video head impulse testing on the lateral canals. However, this was on our old system before we updated things, and there was an equipment malfunction to do vertical testing. So to walk you through this graph of what we're seeing, all the way to the left, it shows the overall eye gain for the left and the right canals. So the left is the blue X and the right is the red X. So those are both within the normal range. And then next to that, you'll see the green lines are showing the trajectory of the eye movement. Faintly in the background here, you'll see this red line, which is the head movement, and the green line is the eye movement that follows. So this is for the right lateral canal, and then here you'll see the blue line in the background, which is the head movement, and then the green line, which follows. You'll also see some, kind of little red spikes that can occur immediately following the head thrust or just after the head has been reset. And in this case, this is just representing cursor or blink artifact. But in the case of a positive head thrust, you would see very large saccadic eye movements, which would represent either covert saccades as the head was still moving, or overt saccades, and that's the one that would be visible to your eye if you performed a bedside head impulse test. So for this system, any eye movement gain that is less than 0.7 degrees per second is abnormal. So for this patient, for lateral canal impulses, similar to what Wendy saw, the gain was normal without any evidence of corrective saccades bilaterally. So again, aside from the equipment malfunction in this case, these VHIT systems can also assess the vertical canals. And so kind of as a reminder, the vertical semicircular canals are arranged as coplanar pairs, where the right anterior canal is in line with the left posterior canal. Conversely, the left anterior canal is in line with the right posterior canal. So we refer to that as RALP and LARP for short. So to test the lateral or the vertical canals, excuse me, the clinician will again stand behind the patient, turns their head 45 degrees to either the left or the right, and instructs them to stare at the fixation point straight ahead. Then the clinician will thrust their head either up and back for testing of the posterior canals, or down and forward for testing of the anterior canals. So just to go over all of the results of head impulse testing so far between Wendy and Devin's evaluation. So the video head impulse testing showed negative horizontal canal gain bilaterally with the inability to test the vertical canals. The bedside head impulse test was negative bilaterally for horizontal canals, as well as the LARP plane. So that again is the left anterior, right posterior canal. That all looked normal. But when Wendy was testing the RALP, so this is just with, visual, kind of clinician standing in front of the patient doing vertical head thrust, the left posterior canal appeared positive with a refixation saccade for 3 reps. So does anybody have any ideas about maybe some other tests that we could perform that might either confirm these findings or anything else you would be interested in learning about this patient?
So you could do VEMP testing, which could help isolate the superior and inferior vestibular nerves.
You got it. So that was Wendy's thought as well. And I think I remember I was off that day and she just called me and I was like grocery shopping, and she was, telling me kind of what she was thinking and about this patient. And, he was still on his school break. And so we were kind of working together to think about what would be most beneficial for him. He was coming back already to have that MRI. I heard someone mention that earlier, that we should get an MRI on this guy because of the questionable central findings and things that we're seeing. So we were able to also add on an audiogram that day. And so the audiogram looks normal. This might be a way for another fellow to get involved. Would anybody like to take us through the results of the audiogram that you see here?
I can do that. Hi, I'm Armina Krishnan. I'm the other fellow, first year. So it's a little, I have to zoom in to see, but is it 34 decibel or 20 decibel? Looks like normal. I mean, maybe a little suprathreshold on the right bone levels, or close to zero, not actually suprathreshold. Gap is pretty minimal, but overall normal audio, I would say, pretty symmetrical, and word recognition scores are normal, and tympanograms are normal.
That's
Yeah,
right.
100.
Yep, 100% word recognition scores. He did have these very small ear bone gaps in the right ear at 250 and 1000 hertz. Not sure exactly what to make of that, but the thresholds themselves are all within the normal range. I also did otoacoustic emissions on this patient, which were present from 750 hertz to 8000 hertz bilaterally. So we had also decided that, just like Susan mentioned, that it would be interesting to get some cervical vent testing on this patient, so we could particularly look at his inferior branch of his vestibular nerve. So here I just want to pause for a moment and give you a little bit of background about how we test. The two main common modalities for vent testing are either cervical or ocular vents. So even though we only recommended the cervical vent for the patient in this case study, I'm going to go over both methods because those are the ones you'll see most commonly. So the cervical vent, one of the important things to remember about that one is it is a relaxation or an inhibitory potential. So therefore the patient does need to turn and isolate the sternocleidomastoid muscle and tense that muscle so that we can place an active recording electrode on it. The vent response, again, is going to be an inhibitory response so that you need to maintain tight tonic contraction of the muscle in order to see it. We use a lower frequency tone burst. 500 hertz tone bursts are delivered via an insert earphone at a loud intensity level. The pathway of the cervical vent is that the loud sound is going to stimulate the saccule, which activates a reflex arc from the inferior branch of the vestibular nerve to the vestibular nucleus, then up the vestibulospinal tract to the spinal accessory nerve before ending in a muscle contraction of the sternocleidomastoid. We will see the largest amplitude response when we measure on the side ipsilateral to the ear we're stimulating. And then conversely for ocular vents, this is an excitatory potential. So for this, we need to put an electrode underneath the patient's eyes. They will direct their gaze upward in order to engage the extraocular muscles, specifically the inferior obliques. We use the same type of stimulus, so a 500 hertz tone burst delivered via the insert phone at loud levels again. So this pathway is slightly different. It's going to stimulate, we believe, the utricle, activating the reflex arc from the superior branch of the vestibular nerve up to the vestibular nucleus and the medial longitudinal fasciculus before ending in motor neurons of the, both inferior oblique muscles, but we typically measure this from the contralateral side of stimulation. So you can see the insert tubing is in her right ear, but we're going to measure the biggest response underneath her left eye. Any question about VEMPs before we go back to this patient's results? And if anybody's putting things in the chat, I apologize. I haven't been looking at that, but we can get answers of any chat questions at the end too.
There aren't any, but I'll let you know if any pop up.
Oh, good. Thank you, Susan. Okay, so back to our patient, to our athlete. So for the purpose of this, exam we were doing on this day, we were less concerned with the threshold of the VEMP response, which is something you might hear a lot, particularly when it comes to like superior canal dehiscence. But we were really looking to compare function of the saccule and the inferior branch of the vestibular nerve in particular, comparing right ear to left ear. So what we did was we went to a louder testing level, so 95 dB hearing level, which should be super threshold, in order to look for either absent responses from either ear or a significant asymmetry between the ears. So this graph you can see for our patient, the squiggly lines on top are VEMP responses from his left ear or not, as the case may be. So there was no observable response at a level of 95 dB. Compared to the figure below, which when we're testing the right ear, we did see a kind of a robust VEMP response when testing the right ear. So for this patient, we're also confirming, in addition to that positive vertical head thrust for the left posterior canal, we're also seeing an absent response when we test his inferior vestibular nerve using VEMPs. So those two things together are really consistent with inferior vestibular nerve dysfunction. So also on the state, he went back and saw Wendy in the clinic. And so the previous time he had seen her after starting on vestibular rehab exercises, he had reported he was about 75% of baseline. So still marginally increasing that and getting slightly better again. Today he's reporting 85 to 90% of baseline symptom-wise. He's started running daily and is increasing the distance by adding a mile each day. That day before all of this testing, he ran 6 miles at his typical training speed and noted minimal oscillopsia, which is great. She tested his balance on the foam surface for 30 seconds with eyes open and 30 seconds with eyes closed. And so that was an improvement over his previous performance, where I think it was only about 10 seconds. She did note some increased sway with vertical and horizontal head movement, so making it harder while he's standing on the foam. Then she had him do some walking. So eyes closed, he did demonstrate mild path deviation to the right at the end of the 20 feet. So, and like we had talked about before, due to the initial concerns regarding peripheral versus central involvement, the patient also underwent an MRI on this date. And so just to give you a little background about the technique, they used a 1.5 Tesla, U of M's routine adult brain protocol, and they did do with and without IV contrast. So these are the findings here. The brain volume, signal characteristics all look normal. They did report some mildly low-lying cerebellar tonsils extending 5 millimeters below the foramen magnum, which I believe was reported as normal. So I think that must not meet criteria for like a significant like Chiari or something like that. No abnormally enhancing lesions visualized, no abnormal restricted diffusion or any evidence of acute infarction. No intracranial hemorrhage was seen. Ventricular system non-dilated without shift of the midline structures, no extraaxial fluid collections and things like this. And then looking at the mastoid air cells and the paranasal sinuses, everything looked well aerated, no evidence of infections. So now just kind of a overview to looking at the structure. So it was very encouraging to see that he had that normal MRI result. So kind of looking again back to peripheral structures. So we just wanted to, remind everybody of the innervation of the two branches of the vestibular nerve. So the structures that are innervated by the superior nerve would include the utricle, the horizontal semicircular canal, and the superior or anterior semicircular canal, while the inferior nerve will innervate the saccule and the posterior semicircular canal. So we can use this information with all of our different testing techniques and see if we can kind of isolate some patterns. So for this patient, he did have spontaneous nystagmus that was, it was left beating, right, Wendy? Yeah. So in the acute phase, so potentially beating towards the ear that was involved. All of the tests we had of horizontal, head movements, looking at the superior nerve, all of that looked normal. One of the big clues was the patient, his report of oscillopsia with vertical head movement. And Wendy actually did test vertical, head shake and things like that, which can, you're just testing a different part of the system. So when we look at the vertical head thrust as well as the absent cervical vamp, those two things are both pointing towards inferior vestibular nerve involvement. You wouldn't necessarily pick that up if you were only looking at the superior nerve function. So just to talk a little bit more about inferior nerve vestibular neuritis, it is much less, it's much more rare, I guess, than the superior branch, the incidence being only 1.3 to 7% when you look at what's published. 55% of patients will have like a total neuritis where both nerves are impacted, and 40% will have just superior nerve involvement. And inferior neuritis, more often or more so than superior nerve involvement, can be mistaken for a central vestibular disorder. Again, most people are doing a bedside head impulse test and they're only looking at the horizontal canals. You also may see this sort of kind of torsional downbeating nystagmus with inferior neuritis, whereas superior branch involvement is going to be more likely to just be horizontal nystagmus. So this slide, it will kind of help walk through the various tests you may have access to, and then looking at the different pattern of findings when we look at superior versus inferior vestibular involvement. So the first test that anybody can do anywhere, which is nice, is the bedside head impulse test. So when we do that test and we're looking at superior nerve involvement, it's going to be positive to the involved side. And this is if you're looking at horizontal head thrust testing. But if the inferior nerve is the one that's affected, it's going to be negative. So you'll see a normal gain, no refixation saccade. We don't have it specified on here, but if you added in the vertical head impulse test, then you might start to see different patterns where you could pick up findings that might point towards the inferior branch. You can do a video goggle exam, so looking for nystagmus in darkness. And with superior nerve involvement, you will typically see this unidirectional horizontal nystagmus where the fast phase will be towards the intact side. Inferior branch involvement, you may be more likely to see the torsional downbeating nystagmus. Whether it's superior or inferior branch, they may demonstrate a vestibular dysfunction pattern on dynamic posturography. So where you put them in conditions where they have to rely on the inner ear, and either with absent vision or having to tune out incorrect visual or somatosensory information, they may demonstrate increased sway or falls. If you do a VNG and you do caloric testing again will test the superior division of the branch by testing the horizontal canal. So if you have superior neuritis, you're going to likely pick up a unilateral caloric weakness. But if you have inferior neuritis, that test could look normal because it's not testing anything with the posterior canal, only the horizontal canal. With rotary chair, you could see asymmetries or possible low gain in superior neuritis, but it might look totally normal in inferior because same thing, where with traditional VNG and rotary chair testing, we just keep testing the horizontal canal over and over again. So when that nerve is not affected, everything will look normal for those tests. And then you can do VHIT. So this is the video head impulse testing. For superior vestibular nerve findings, you're going to get low gain for horizontal canal and potentially anterior canal versions of the RALP and LARP. For inferior vestibular neuritis, you're going to get low gain when the posterior canal is tested on the affected side. And then finally, the VEMP testing can really help you differentiate superior from inferior nerve involvement. With superior neuritis, your OVEMP is going to be low or absent. And in inferior neuritis, your CVEMP is going to be low or absent. This is one of those slides that's good to just save and pull back out at some point when you're kind of walking through a particular case. And then, so we did reference here an article walking clinicians through the diagnosis of inferior vestibular neuritis. The patient should present with a sudden severe vertigo, typically lasting less than 24 hours. But it's usually not positional in nature, although it could be exacerbated by movement, but more of kind of an ongoing abrupt onset severe vertigo. They will likely not have any other auditory complaints of hearing loss or tinnitus, although they might. And typically there are no other like focal neurological findings. If you do a VNG, they will probably have normal caloric responses. But then on VEMP testing, you would see either loss of amplitude or an absent response on CVEMP testing with a normal OVEMP. All right. So before we kind of go to take home points, any questions about that? Does anybody have any comments or questions they want us to expand on? I know I kind of walked through some of the testing a little bit quickly.
I have a quick question. How you test
Yeah.
on rotator chair? How are you testing inferior superior vestibular nerves? I thought they are tested together. Do you mostly look at the compensation, right? Gain?
Right.
Or
Yeah.
I'm just
So
wondering.
the head position that the patient is in for rotary chair, they're seated upright with their chin tipped down slightly. So what we're doing is we're putting their lateral canals in the plane of rotation, right? So like a pure, like perfectly positioned patient with their head down, we would not be stimulating the vertical canals at all because it's side to side horizontal rotation that's in the plane of the horizontal canals. So that's why we kind of just say, just same with the caloric, that, you know, we're really just looking at horizontal canal function with those tests. That's a good question.
Thank you.
Yeah, so then we just wanted to kind of wrap up a few things as take-home points that we learned from this case. So the first thing, of course, is history. It's so important. So you know, really taking that time to listen to the patients, you know, and probing things about the onset of the dizziness, the characteristics of it in terms of what type of dizziness they're experiencing. Is there any, you know, were there any inciting factors, anything that makes it feel worse or makes it feel better? If there are any other auditory complaints that go along with it, those type of things. And then the bedside exam can actually assist you in terms of kind of making quick assumptions about things you can maybe rule out or focus on. In terms of like what should your next steps be. You have, just because you have access to all kinds of testing doesn't mean that every person always needs them, right? So so it can lead you to your next steps. So for this patient, doing that video goggle exam to look for evidence of spontaneous nystagmus and looking at the characteristics of the spontaneous or gaze evoked nystagmus was helpful, as well as the, you know, ocular motor exam, looking at the saccades in pursuit. Doing the horizontal and the vertical head thrust turned out to be very important to this case. And then just utilizing other available resources. You know, in our clinic, like we mentioned, we work closely together. So, you know, sometimes we are able to just, you know, come out and immediately provide input. But if you're in a clinic where you have access, you know, work with a team of audiologists like you all do, they, you know, you can schedule things like audiograms, vestibular evaluation, the VHIT testing, VEMP testing. Or if you work and have a referral network of vestibular PTs, you know, kind of finding a place where you can send patients to would be also very important. Because there is evidence that you should start them on their vestibular PT early, so early on in the acute phase. So if you do see patients that are acutely dizzy, getting them hooked up with a vestibular physical therapist, even if you don't have the diagnosis totally sorted out yet, will, you know, has proven to be beneficial to patients, kind of get them working on things and getting back to their baseline, because we want to start that compensation process, right? The other thing that's important to note, and you should be counseling patients on, are, of course, are factors that can affect compensation. So things like lack of sleep, stress, other illnesses going on. So just kind of making sure that they have, are maximizing those other things that they do have control over is good. We do know if there are also any underlying central pathology going on, that will affect compensation as well.
And then I think, Crystal, also in this category is the medication. So not
Mhm.
taking the meclizine forever.
Yes, very important point that I think I would have forgotten, because he was also on benzos, right? He was doing like this combination of meclizine and benzodiazepine, which is,
He actually
to
opted
bust up
not, to take those. So that was good in this case.
It was good in this case. Yeah.
Yeah.
Yeah. So that's the other thing is, our doctors, one of the first things they do is they talk about the medications people are on, and, the fact that that could be limiting their recovery because it's just suppressing all of that vestibular response. So they need to kind of press on and do their vestibular PT, and those things are definitely much more likely to show improvements in the long term. So we did also want to add here some of our patient education resources through U of M. We have these resources under our Care Guides website, where it includes videos of exercises and handouts that patients can go on, and we can assign them if they've seen a therapist. But those are open for anyone to look through. So there's, for a lot of the exercises, also videos, links that can be viewed, and then PDFs of the exercises themselves to be printed out. And then actually, Veda, this vestibular organization's very focused on patient materials, finding vestibular PTs, people who are certified vestibular PTs in your area. And a good resource if patients want to go on the internet and read about stuff, can make sure that they're reading some good information. Wendy, do you have anything you want to add about the care guides or the exercises?
No, I think just pointing out, finding the clinician has been very helpful. Yeah.
Yeah. And then really, actually just realized we didn't really put in any final word about our patient, but as far as we know, he did make a full recovery, right? He was able to
Good.
fully compensate. There really wasn't any other evidence of central pathology, as he got out of that acute phase of the neuritis. And then, he had went on, and he knows we're here if he needs anything, if he decompensates in the future. But yeah, I think as far as I know, Wendy, you haven't seen him back, right?
No. And I think one of the things in reflecting on this case, I think one of the things that made him not recover quite as quickly as you would expect a young athlete was just the stress of the finals happening during that time, that acute time.
Yeah, bad luck. So, okay, so here are some references we used in this presentation. Anybody's welcome to, do any further reading. And then I will also put up our contact information. We would be happy to answer any questions you all may have now, or if any come up later. And yeah, I just wanted to say thank you for letting us speak with you today.